So let's bring up an example of a basic 12 lead again. If we look at our leads here and group them together again, we'll show the different contiguous leads that we have. We're going to start off with leads 2, 3, and AVF, and these leads are looking at the inferior portion of the left ventricle. Now leads 1 and AVL are what we consider the high lateral wall. V1 and V2 are our septal leads, looking at the septum, as well as giving us some anterior view. V3 and V4 are what we call our anterior leads, looking at the anterior of the left ventricle. And then finally, V5 and V6 are our lateral leads, looking at the lateral side and the apex of the left ventricle. Now, there's really not many things that I tell you guys that you really need to memorize on this channel, but this chart and these contiguous leads really is something you should commit to memory. It's really not that difficult once you know the pattern, so I really strongly urge you to do so. And one thing to note with our typical 12 lead configuration is that we're not going to have a direct view of either the posterior wall of the left ventricle or the right ventricle. So I will discuss this briefly later in this lesson, but to view each of these, we would need to place some of the leads in different locations. Now, knowing the region of the heart that's being impacted on EKG, we can then combine this with our knowledge of coronary blood flow, again linked to that lesson up above, to have a pretty good idea of the blood vessel or vessels that perfuse that area of the heart. So for instance, if we look at our inferior leads 2, 3, and AVF, most people, so about 90%, are actually perfused by the right coronary artery, while 10% are perfused by the left circumflex. Now for leads 1 and AVL, our high lateral leads, that these are perfused by the left circumflex. Septal leads V1 and V2 are actually perfused by the left anterior descending, or LAD. The anterior leads V3 and V4 are also perfused by the LAD. And then finally, the lateral leads V5 and V6, they can be fed by the distal LAD, the left circumflex, or the right coronary artery. Now, to complicate things more, we don't always just see one area or region that's impacted. We can have multiple areas such as anteroseptal, anterior lateral, or even inferior RV, just to give you a few examples. I will briefly hit on this lesson, but just keep this in mind that when evaluating EKGs, it's not always clean cut with just one region impacted. Alright, and then the last thing I want to cover real quick before we look at our STEMI EKGs is the concept of reciprocal changes. Again, I did briefly mention this in the AMI intro lesson, but I just want to hit on this again here. Due to the size and magnitude of injury that's taking place with STEMI, along with all that abnormal depolarization, that not only will we see the ST elevation in the leads directly viewing them, but the leads that are opposite or looking from the other direction will actually pick up this large electrical activity moving away, thus giving us ST depression. So this is what we refer to as reciprocal changes, and these are commonly seen in patients having STEMI. Okay, now that we have all that information covered and out of the way, let's start to look at some EKGs of STEMIs in different regions of the heart. And to help with the identification, I am going to keep this chart up top, kind of showing our infarcted regions. Alright, so let's start off looking at our inferior wall. So remember, this is seen with leads 2, 3, and AVF, and is typically perfused in 90% of people by the RCA, and the other 10% is the circumflex. Our reciprocal changes typically present with ST depression in the high lateral leads 1 and AVL. So if we take a look at our EKG here, you can see clear ST elevation in leads 2, 3, and AVF, along with those reciprocal changes of ST depression in 1 and AVL. This is our classic inferior wall MI. Now, on the subject of inferior MI, knowing that most people have this region perfused by the RCA, we also would be concerned that the patient would have some RV involvement and could have an RV infarct as well. If the patient is having an RV infarction and the RV is weakened, remember that the right ventricle is very preload dependent. The right atrium helps to push the blood flow forward to fill the right ventricle. This process is still primarily driven by venous return. Giving a vasodilator such as nitroglycerin or even morphine could significantly impact this preload and could have significant effects on your patient's hemodynamics and blood pressure. So I've actually seen patients with very good blood pressures that actually quickly plummet after being given sublingual nitro, so it's definitely something to be aware of and to evaluate when you have an inferior MI. So if you do identify an inferior STEMI, before you consider giving nitro for chest pain, you really should get a right-sided 12-lead EKG. To do this, it's pretty simple. We actually keep our limb leads where they are, and what we do with our precordial V leads is we do a mirror image on the patient's chest. What this means is that V1 is now going to be the patient's left sternal border, fourth intercostal space. V2 is now going to be on the right sternal border, fourth intercostal space. V4, we are going to have on the patient's right side, midclavicular line, so that nipple line, fifth intercostal space. V6 is again along that mid-axillary line, fifth intercostal space, on the same horizontal plane as V4. And then V3, we want to put kind of diagonally in between V2 and V4. And then V5 is going to be in the middle of V4 and V6, again along that horizontal plane. So this is going to give us a view of the right ventricle and really help us identify any RV involvement and determine whether the patient should be considered for sublingual nitro or whether we also want to be concerned with like morphine administration as well. All right, so now let's take a look at an anterior wall MI. So remember that these are leads V3 and V4, and this region is going to be perfused by the LAD. So reciprocal changes are not going to be seen as they would actually show up posteriorly, which, like I mentioned, we don't have a view of with our traditional 12-lead setup. Now, a true isolated anterior wall MI is actually pretty rare. And so this is actually going to segue into a concept that I mentioned earlier, talking about multiple regions being impacted. Oftentimes when we see an anterior wall MI, it's going to be combined with a septal wall MI, something we call anteroseptal involving V1 through V4, as well as extending into the lateral wall, so an anteroseptal with lateral extension, which we'd also see in V5 and V6, as well as potentially in 1 and AVL. So here's an example of such an EKG. In this example, we have a lot going on here. You should pretty easily be able to see the ST elevation meeting all criteria in leads V2, V3, V4, and V5. But if you look at V1, you can also see ST elevation there, and V6 is a little harder to see, but especially if we look at the last one here, we can see the ST elevation as well. So seeing all these areas of ST elevation, we have it in our septal region, our anterior region, as well as that lateral apex region. In this example, we don't see any ST elevation in our high lateral leads, so 1 and AVL, but we do see the reciprocal changes in 2, 3, and AVF. So given the rarity of an isolated anterior MI, here's actually an example of the closest I could find to that. In this example, we definitely have ST elevation in the anterior leads V3 and V4, but hopefully you also see the ST elevation in V2 and V5. So V2 being septal and V5 being lateral. So this really isn't a true isolated anterior MI. All right, now let's talk about the lateral wall. So here we would see our ST elevation in 1 and AVL being our high lateral, as well as V5 and V6 being our lateral or apical. So the left circumflex feeds the high lateral, and for the lateral apical region, this can be any of the three, so LAD, circumflex, or RCA. Reciprocal changes from the high lateral region are seen in the inferior leads, so 2, 3, and AVF. A lateral wall MI can occur by itself, but it's also commonly seen in combination with other regions, such as anterolateral, anteroseptal, with lateral extension, as well as inferolateral, just to name a few. So in this example here, we can see clear ST elevation in leads 1 and AVL, but also V5 as well as probable elevation in V6. We do have our classic reciprocal changes in the inferior leads 2, 3, and AVF, but we also see some ST depression in the anteroseptal leads V1 through V3. These could be reciprocal changes, so maybe think posterior MI in left-dominated patients, or ischemia in those regions as well. All right, and so speaking of posterior MI, as I mentioned, this region is actually one that we don't have a direct view of with our typical 12-lead EKG. That said, we do have a good view of where our reciprocal changes would be. So given a posterior MI, we would expect to see reciprocal changes in the anterior and septal leads, so V1 through V4, typically seeing this greatest in either V2 or V3. If you see this on an EKG, you should be suspicious of a posterior MI and get a posterior view 12-lead EKG. So again, this is also pretty simple to do. And to do this, basically you're just going to take leads V4, V5, and V6 and move them posteriorly, giving us what we call V7, V8, and V9. To place these, V8 is going to be mid-scapular line, the fifth intercostal space, with us then placing V7 on the patient's left along the axillary line, same fifth intercostal space and same horizontal plane as V8, and then V9 is going to be placed to the right of V8 along the spinal border, again fifth intercostal space, same horizontal plane as the other two. So this is going to give us a view of the posterior of the heart with those leads V7 through V9, and thus we'd be able to actually see ST elevation in these leads if a posterior MI was present. Now also of note, posterior wall MIs are commonly seen combined with inferior as well as RV infarcts. So as an example of just this, here's an EKG with high suspicion for a posterior wall MI. You'll note the deep ST depression in V2 as well as depression in V1. It looks like some in V3 as well. Along with that, we also see ST elevation in leads 2, 3, and AVF, with some reciprocal depression in AVL, indicating inferior wall MI, as well as some lateral involvement with elevation in V6, and looks like some in V5 as well. But given the anterior ST depression, especially the magnitude of it in V2, we would definitely want to get a posterior view to check for posterior wall involvement. All right, and then finally, the last thing I want to cover quickly here is left bundle branch block. So left bundle branch block holds a special place when it comes to MI. So first, it can complicate the recognition of STEMI, as a left bundle branch block can produce ST elevation and T-wave changes that are pathologically normal for these patients. That can either give the false impression of a STEMI or actually mask a STEMI that's taking place. That said, patients with left bundle branch block can still have MIs, which is something I'll actually be diving into further in the next lesson. But in addition to that, a new left bundle branch block, especially in the presence of signs and symptoms of ACS and chest pain, that we consider this a sign of STEMI. So a study actually looked at this and took patients with new left bundle branch block and chest pain to cath lab and often found a complete occlusion. Sometimes, though, we don't always have a previous EKG to compare to, so when in doubt, if the patient presents like an MI with a left bundle branch block, we should consider it as such. We can also use something called Scarboza's criteria, which I am going to be discussing in the next and final lesson of this series to evaluate for acute STEMI in the presence of left bundle branch block. Alright, well, we covered a lot of information in this lesson, and this was a lot of really important information, as being able to identify acute myocardial infarction on EKG is probably one of the most important things to be able to do.